As the 16th biannual AIDS conference wraps up in Toronto, delegates from around the world await to see what has come out of a week of discussion and debate. The conference was attended by 20,000 representatives from all over the globe, each one attending a wide variety of events concerned with a different aspect of the global AIDS pandemic. Among the attendees were Bill and Melinda Gates, former President Bill Clinton, Richard Gere, and UN Special Envoy to AIDS in Africa, Stephen Lewis, most of whom possess positive views on the future.
Today, more than 1.3 million people are receiving treatment. We didn't make it to 3 million in 2005, but soon we will, and go beyond.
The celebrity of these high-profile delegates ran rampant throughout the week, although some AIDS activists felt it detracted from the true focus of the conference.
It's not Bill Gates or Bill Clinton who've made the difference in this epidemic, despite their welcome to this meeting as some sort of royalty. The seduction of money and power that they represent have blinded us to what they've really delivered to us.
Clinton and Gates. Their recommendations were welcome ones that most people can agree with. But is it wise for a conference agenda to be so influenced by an ex-politician and a billionaire as opposed to people living with HIV?
Beyond the politics, much of the conference focused on universal access to treatment, particularly in the developing world.
Last year, world leaders committed to achieving universal access to treatment, prevention, and care.
Universal access demands the universal response.
We've heard from several speakers and we've seen the evidence that where treatment is freely provided, outcomes are better.
Is that a large portion of the world has still not yet gotten the advantage of those scientific advances. This slide says that of December, there were 1.3 million people receiving ARVs. Just this morning, the announcement is that there's 1.6 million, or 25% of the people who need it. We are still 75% away from where we need to be when we're talking about getting drugs to those who need it.
As has already been said, we need more nurses. Until we get them, universal access is just a mirage.
Treatment is keeping people alive. Treatment is bringing hope. Treatment is stimulating prevention. Treatment is meshing more and more frequently with community-based care. We cannot let the process slow.
We can be successful in treating HIV, in treatment naive and in treatment experienced, in people of all ages, and in rich and in poor countries, and we need to do more.
One obstacle that the conference spoke heavily about is the U.S. policy of abstinence-only prevention.
Abstinence-only programs do not work.
Forces that insist on strategies of abstinence and moral purity.
Empowering women to protect themselves seems so elemental, and yet when I hear people pontificating about AIDS and acting as if we can do everything through abstinence, I think they don't know what most women are up against in too many parts of the world.
Ideological rigidity almost never works when applied to the human condition. Moreover, it's an antiquated throwback to the conditionality of yesteryear to tell any government how to allocate its money for prevention.
In South Africa, there lies an even bigger issue in the outright denial of the AIDS epidemic.
And it is correct that we ask how many additional millions of HIV cases are attributable to the failure of certain world leaders to directly and honestly address issues of HIV/AIDS with their people.
South Africa is the unkindest cut of all. It is the only country in Africa, amongst all the countries I have traversed in the last 5 years, whose government is still obtuse, dilatory, and negligent about rolling out treatment.
In South Africa, as an example, which has more cases of HIV than any country in the world, it is unconscionable that government leaders still do not speak openly about HIV and instead talk about lemon juice as a key prevention strategy.
Between 600 and 800 people a day die of AIDS in South Africa. The government has a lot to atone for. I'm of the opinion that they can never achieve redemption.
While many focus on the pandemic in Africa, Asia, and Eastern Europe, Canadians are not in the clear. Infection rates have gone up in the past year.
Yes, the number of infections are on the rise, and in the Aboriginal community it is really, really serious, and infections are on the rise amongst women. And that is true everywhere. And women are always the vulnerable group. So Canada itself has a serious pandemic which it has to address. The numbers are relatively small, of course, but you have 50 to 60,000 people infected. You have to take it seriously.
Another issue directly affecting Canadians is the potential closure of the Insight Safe Injection Facility in Vancouver.
And the biggest example for the people here in Canada is the policymakers' refusal to extend a legal exemption permitting the operation of the first safe injection drug site in North America.
Needle exchange and methadone treatment save lives. More, it would be positively perverse to close the Insight Safe Injection Facility in Vancouver.
The research challenge is to learn operational lessons for the urgently needed expansion of harm reduction programs, including the renewal of support for Canada's only supervised injection facility from the Harper government before the September 12 exemption deadline.
Russia, Central Asia, parts of India are all struggling with transmission through injecting drug use. To shut Insight down is to invite HIV infection and death. One has to wonder about the minds of those who would so readily punish injecting drug users rather than understanding the problem for what it is, a matter of public health.
AIDS is an issue that affects everyone, and as delegates return home and organizers begin planning for the 2008 conference in Mexico City, there is an overwhelming feeling of hope that this conference has helped in the fight against this disease.
We recognize that we still have a long way to go. We also recognize that the next years will hopefully bring us closer to our dreams of both providing even better and cheaper drugs for the treatment of all those infected by HIV than we have managed thus far. And of course, and above all, that we will succeed in our goal of bringing HIV drug access to everyone in the world at need, regardless of ability to pay.